Para quienes no me conocen, yo soy médico, soy el doctor Hosp, soy el coordinador de educación médica continua y desarrollo profesional médico continuo del Hospital Británico. Nosotros a lo largo del año realizamos muchos eventos y este viene a ser casi de los primeros del año que vamos a realizar. Quiero dar las gracias a Henry Cohen de haberse acordado de nosotros, al apoyo que ha dado incondicional a este evento de Embajada Británica a través del señor embajador Benjamin Desafío. Y quiero dar especial gracias por haber elegido este hospital, para quien el título de esta conferencia el desafío, el hospital le gustan los desafíos, de desarrollar cuidados paliativos, que es una necesidad sentidísima en este hospital, y además dice que es un hospital moderno, que nosotros nos creemos un hospital moderno, nos gustaría ser un país. Quiero entonces darles a todos la bienvenida a esta casa y le pido a Henry que haga la presentación formal del invitado. A Henry como director del proyecto ECO, proyecto que conocí a través de unas reuniones que teníamos de primer del doctor Álvaro Manuel y aquí presente, donde presentaron tratamientos de la hepatitis C a través de tecnología de New México. Cierto, buenas tardes a todos. Es cierto, porque tú hiciste algo que no debías hacer, y le voy a decir acá delante de la doctora Otto. Hiciste una traducción ilegal, un ejercicio ilegal de la traducción, pero muy útil, porque fue la primera vez que conocí un salto positivo ahora públicamente. Bueno, ahora voy a empezar formalmente. Es muy divertido que quisieras acordar esto. Señor embajador, muchísimas gracias por el apoyo que nos ha brindado. Siempre digo que lo mejor en la vida es tener amigos. Fue una amiga, la embajadora Reynoso, que me introdujo al embajador, que rápidamente comprendió la importancia del proyecto ECO y dio su total apoyo y aceptación para que trajéramos al profesor Watson. El profesor Watson es profesor de medicina en Irlanda del Norte, es una máxima autoridad en el tema de cuidados paliativos en el continente europeo. Yo lo conocí en el mes de septiembre en Albuquerque, en la primera reunión que hubo de todos los proyectos ECO del mundo, tratando justamente de hacer uniones y de hacer vínculos entre los diferentes grupos para que podamos realizar trabajos en conjunto. Tuve la suerte de que ambos llegáramos a la noche previa y nos encontráramos en los brindis y que rápidamente pudiéramos hablar de Luis Suárez y de cosas así que se hablan con los uruguayos cuando se conocen, y que a él también le gusta el fútbol, y que cuando me encontré lo que él estaba haciendo en Irlanda del Norte, dije que se tiene que venir, y rápidamente contacté a la doctora Gabriela Piris, que quiero que se levante su mundo para que me conozcan nada más, no le voy a pedir que hable ni nada, pero la doctora Gabriela Piris es la verdadera líder en el tema de terapias paliativas, de cuidados paliativos en Uruguay, y es quien va a liderar y ya está liderando este proyecto con el profesor Watson. Yo les voy a quitar 2 minutos del tiempo del profesor Watson, porque la mayor parte de ustedes seguramente no saben que es el proyecto ECO. Sanjeev Arora, que nos presentó el doctor Margoli, es un médico nacido en la India, que hace más de 20 años en Estados Unidos, que muy preocupado porque sus pacientes no tenían acceso a los cuidados de salud que merecían solamente por el solo hecho de vivir lejos de las grandes ciudades, y tenía una lista de espera muy grande para llegar a ser atendidos, inventó o creó este proyecto mediante el cual educa a los médicos radicados en el interior, en pequeñas ciudades, en pueblos, en áreas rurales y aún en establecimientos cerrados, como son establecimientos de detención o cárceles, los educa para que mejoren sus conocimientos de determinadas enfermedades y luego le da un apoyo de forma semanal porque le conferencia por todos los sistemas de comunicación. Esto es una verdadera revolución. Desde que él empezó hace 11 años con el hepatitis C, hoy ha incorporado más de 26 enfermedades. Hay 33 centros en Estados Unidos, la mayor parte de ellos universitarios, nada menos que la Universidad de Harvard, de Chicago, de Washington, está incorporada a esto. Todo el sistema de veteranos, hay más de 1000 clínicas trabajando en el proyecto de solo en Estados Unidos, y hay varios países como Irlanda del Norte, como Canadá, como India, como Uruguay, Uruguay, que tenemos el orgullo de ser el primer país en América Latina que incorpora el proyecto de eco. Estamos convencidos de que esto es una revolución buena, es una revolución rápida, en la cual podemos democratizar el acceso a la atención médica y demonopolizar los conocimientos médicos. No hay que ser un gran especialista en gastroenterología o en hepatología para diagnosticar y tratar una hepatitis C. No hay que ser un gran especialista viviendo en la capital de Irlanda del Norte para atender adecuadamente a un paciente en su primera etapa de la vida. De eso se trata ECO, y se trata de la participación de la comunidad. Es una extensión a la comunidad. Y todos ustedes, médicos, enfermeras, psicólogos, familiares de pacientes que han vivido situaciones difíciles, saben que lo que estoy diciendo es la pura realidad. Los invitamos a todos a participar a partir de ahora del programa ECO. Max, please, we welcome you very much, and we are very, very pleased that you came to Uruguay for a full week to share your knowledge.
Buenas tardes. I am very sorry, but that is the extent of my Spanish. You've done it all. I am sorry. It is a fantastic honor to be in Uruguay. I got caught up with the passion of Dr. Cohen in Albuquerque and his vision for what ECHO could do in your country. I share that vision, that potential of what ECHO can do in terms of taking expert knowledge and having it spread where it is needed most, where people need it most. Tonight, I've been asked to talk about the challenge of developing palliative care services in a modern hospital. And these pictures from the net, I think this hospital here, it has already changed from these images. You have opened a brand new, exciting hospital. And a hospital where I hope in the future there will be very much a place for palliative care. That's what we're going to be talking about over this next 40 minutes or so. At the outset, I have to declare my interests. The first interest is that I am an enthusiast about palliative care. I have worked in palliative care for the last 20 years, and I find it the most rewarding branch of medicine, even more rewarding than gastroenterology, because we always have the chance of helping our patients, no matter where they are on their journey. And so I confess that I'm an enthusiast. I need to say thank you. I need to say thank you to Dr. Cohen and to the ECHO team, to Eliza in particular, who has worked so hard to make this trip possible. And I need to say also thank you to the British Embassy and to the Ambassador for making it possible from a finance point of view. So we're very grateful for tonight. What I was planning to do was to kind of give a bit of an overview of why I think this is important. Why is it important enough for you to have given up a night, a fantastic night, when it should be so much colder, as I understand, but a night to enjoy the summer again? You've given that night up. Why? I hope I can share with you why this is so important. The personal challenges of palliative care, the professional challenges of palliative care, the communication challenges of palliative care, all these things which make it difficult for a modern hospital to adopt a palliative care approach and to develop a palliative care service. And then the organizational challenges, maybe the most difficult of all. How is it that we can really incorporate palliative care when at the same time we're spending so much money on developing our curative services? How do we balance those two really important needs? And then some thoughts on the ways forward. What can we learn from what others have done in other countries, in other places, to develop the role of palliative care, which is so crucial in our modern medicalized world. So, why is it important? I want to begin by telling you a story. This is Karen. Karen came into our hospice back in August of last year. She came into the hospice with a clear goal. She had stomach cancer, which had spread to her liver, And she came into the hospice because she wanted to get built up so that she could withstand the chemotherapy, so that she could have more time with her little girls, aged 9 and 4, with her husband. She was very ill when she came to us. She was sore, she was dehydrated, and so we used our palliative care knowledge to control her pain, to get her feeling better. But the major problem was that her disease had spread beyond the point where chemotherapy or oncological treatments could make a difference. And yet she was holding out for that treatment that was going to get her more time. And so we had a choice to make. We felt we needed to tell her that there wasn't a cure. Because if we didn't tell her, she was going to continue looking for a cure that didn't really exist. The nurses were not keen, they thought this was too cruel. But we felt it was the right thing to do. And so it was very difficult conversations, coupled, spread over some time. We explained to her that the disease had spread beyond the point where treatment was possible. She was devastated. She didn't speak, she didn't want the girls to come and see her for 2 days. She didn't eat for 2 days. And we thought, have we done the right thing? And then she kicked into gear all of a sudden. The girls were brought, there was lots of planning done, there were memory boxes created. Her husband, he got deaf with all the orders that she was giving him of the things that needed to be done and the things that needed to be put in place. They organised a special night where they took over the outpatients. It was all decorated. It was a double bed for the couple. There was a tent for the girls. There was music from one of our top hotels in Belfast. She used all the time that she possibly had to create as good a memory for her girls as possible. Karen died last September. This photograph was one of the last things that she had on her list of things that she had to leave for her girls. After she died, she even arranged for her eyes to be donated and for the tumour to be sent to a cancer hospital in Leeds. She seized every moment of the life that she had. But without palliative care, that opportunity would have been lost. I think this is really important stuff. That's why I'm passionate about it. Why also is it important? These are the world death rates. You can see they're the same in every single country. And at the moment, even in Uruguay, even in this room, they are at 100%. It's coming to a place near you soon. My job is secure. This is something that we all have got to come to terms with. Some find it more difficult than others, but it's something that we have to come to terms with. And palliative care is about making that important part of life as good as it possibly can be. Why is it important? Well, a long time ago, I had a little bit of hair. Not very much hair, but you can see it clear. It was good. It was great. I worked for 8 years in Nepal, in a rural clinic in Nepal. And every day at the clinic, I was seeing about 40 or 50 patients, often traveling over all of North India, coming to see the white doctor in the mission hospital. And so many of those patients were palliative care patients. They had spent lots of money going from one doctor to another doctor. They were given vitamins, they were given drips, they were given all sorts of medicines for treatments which were futile, that weren't going to make a difference. This lady had no money. She had to sell her field in order to come on that trip. And yet, I had nothing to say to her, but to tell her that her disease wasn't curable, that the way forward for her was to go home with good pain control and to spend her time with her family in the place that she loved. Every day across North India, hundreds of people are dying on trains looking for cures that don't exist. Palliative care is important. Why else is it important? It's important because we know that palliative care is cheap. It's not expensive. People have been dying from the beginning of time. Uruguay has been doing palliative care long before there was such a specialty. Uruguay, with your culture of care, of family involvement, of compassion for each other in your families, that is such a palliative care philosophy. So we don't need a specialty to teach us how to do this, but sometimes the skills of that specialty can help us. What are the key things that we know about end-of-life care? Well, they're universal. They apply as much in Nepal or Ireland or Uruguay. What do people want at the end time? Number one is they want somebody they can trust. Somebody who's traveled the path, who knows, who can be trusted. A doctor, a nurse, a close relative, someone they can trust. They want family, by and large, close beside them. Or, if not sitting completely around the bed, at least in the area. You know? They want good symptom control. They do not want to be in pain or to be nauseated. They want to be ideally in their own home or in a safe place. And I understand 80% of people in Uruguay will die at home, largely because of the care of family supporters. And they want the opportunity to plan. When I went to Nepal, I was told Nepal is different from your individualized Western culture. In Nepal, we never speak to patients. We always speak to the families. We don't speak to patients. We're very respectful. Yes, but we began to wonder, was this true? And so we did a study. We interviewed 300 people on the streets of Kathmandu. We asked them, if you had cancer, would you want to know? And the answer in Kathmandu, I think it's the same as in Montevideo, because it's the same as it is in Belfast. 90% of people would want to know. And approximately 10% really would prefer not to. 90%. Why do they want to know? They want to know so that they can make choices. They want to know so that they can plan for their husbands, for their wives, for their children, for their family. They want to know so that they can make choices. And it's the same in Nepal, and I suspect it's the same here, the opportunity to plan. So these are things that we can deliver if only we know how to, and we've got the direction to do so. What is good palliative care? Good treatment plus compassion. What I think is that in Uruguay, you've got compassion in bucket loads, and you're developing the skills through Dr. Pires and others who are developing the palliative care process and approach to make a dream team of combination. Why is it important? It's important because this is a snapshot of the use of morphine. There's a website which looks at the amount of morphine each country uses legally. And I was comparing Uruguay with Ireland. Not because I think Ireland is the most wonderful place, but Ireland isn't too dissimilar in size. We have a population in Ireland, that's the south of Ireland, of about 3.5 million. Not too dissimilar. We have big neighbours, not dissimilar. We play football, but not as well. I'm sorry, but we've got very good teeth in Ireland. Which maybe is not dissimilar. But if we look at this little figure here, we see that, you can't see it clearly, but the per capita volume of morphine in Uruguay is 7.4 milligrams per head of population is what you use in the course of a year. That's higher than most of your neighbours. But if we compare it with Ireland, you'll see that we're using nearly 300 milligrams per head of population. Why is that important? Because we think that the use of morphine is an indicator of how much pain is tolerated within a society. So I'm saying that there is an opportunity to develop. Why is it important? This is really important study, published in the New England Journal of Medicine, which is close to biblical authority in medical terms. A study in 2010 comparing patients given chemotherapy on its own and chemotherapy with palliative care. And it showed that those who got early palliative care not only had better quality of life, not only had less depressed symptoms, but they lived longer as well. There is a myth out there that palliative care is all about dying. Actually, our focus is on living, on making life as good as it possibly, long as it possibly can be. And once you actually control people's symptoms, they have more energy for living. This study showed it for the first time. So then, what are the personal challenges for doctors and for nurses, maybe those working in our hospital here? And there are many personal challenges. I read this book recently, Atul Gawande, Being Mortal. He's an endocrine surgeon from Harvard in America. And he has all the personality disorders that some surgeons maybe have. That's an awful thing to say. but that drive, that belief, I can fix it, which is what you need. And I don't, if my appendix ruptures, please don't bring a palliative care doctor to me. I want a surgeon who can fix it. Yeah? There's horses for courses at the right time. But, and so the personal challenges, very few go into medicine because they want to do palliative care. They want to fix things. I didn't come into medicine to let people die. Something else I've heard, while there's life, there's hope. I've seen patients who everybody thought were dying, who recovered and are now able to enjoy life. So I never want to give up. And you can understand that. You can understand it. It's important to not remove hope for patients and families. But palliative care is not about removing hope. Palliative care is about giving life. Families often ask me not to tell patients in case they give up. I wonder, is that your experience here in Uruguay? Are people nervous here about you being open and honest with families? Sometimes. And that's really difficult then. What do I do? Do I disappoint the family? And your first priority is the patient. But how do you hold that together? Because you don't want conflict. The patient needs everybody on their side. It's too early to refer to palliative care. Oh, that, as a palliative care person, that really hurts, that one, because it happens so often. And that's because there hasn't been an appreciation of what palliative care is. And the doctor is doing a really good job, the surgeon is doing a really good job, long-term relationship with the patient, the disease is developing, the patient asks, would it be possible, appropriate for me to be referred to palliative care? And the doctor says, it's too early. And it's kind of like the belief is that palliative care is only for the last 2 minutes of life. And at that point, there's so little even Dr. Pires can do at that point, because we need relationship. We need a parallel track in which the curing doctor is working alongside the palliative doctor, working together. Dr. Gawande tells a story of an oncologist who had worked with a patient over many years, had given third-line chemotherapy, fourth-line chemotherapy, fifth-line chemotherapy, and the patient was now deteriorating again. And the doctor, he felt it was best to proceed with trial sixth-line chemotherapy, rather than to explain to the patient that there was nothing more that could be done. The conversation was more difficult than arranging chemotherapy. And you can understand that. But how sad for the patient and for the doctor. This study was done by Joanne Lynn from Washington. I think it's a really important little study. She asked American physicians if it was that they were dying, would they like a little bit of a benzodiazepine? Not a huge amount, just a little bit, just to take the edge off things at the end of life. 98% of American physicians said yes, they would. Then they were asked, how many of you have ever prescribed benzodiazepines for your patients? And the answer, 2%. 2%. So what we doctors want for ourselves, often we're reluctant or we're afraid, or there's lots of other reasons why we're unwilling or unable to prescribe it for our patients. I thought that was interesting. So how do we assess then whether the care that we're giving as palliative care doctors is good enough? I'm going to suggest to you that this is the only real standard. And that it's this. If this were my mother, my father, my grandmother, or this were me, would I be content with the quality of palliative care that I was giving? If I would be when I leave that patient, then I'm probably hitting a reasonable standard. But if I would be very upset if a doctor had given that sort of palliative care to someone that I loved, then it's an opportunity for me to reflect and to think about how I can maybe do it a little bit better the next time. I'm now getting very, very old in my medical life. And one thing I've learned above all else is that success hasn't taught me hardly anything. I've published books, so what? I've done stuff, so what? What really teaches me is when I make mistakes, is when things go wrong. And in terms of palliative care and the acute hospital setting, what I'm really conscious of is that we have the capacity in a place like this to provide absolutely superb palliative care. But we also have the potential in a place like this to provide disastrous palliative care, leaving long-term problems for families and complaints which the admin people have got to deal with. What I would suggest to you is that our gold are those issues when things go wrong. But the problem is when we don't see them as gold, we see them as annoyances. Can I show you this little video? The problem, and that is the problem, that you will see the same thing being done again and again. There hasn't been learning. I've delivered really poor quality palliative care. I'm sorry that I've done it. But I've tried when I've done it to reflect on it so I don't do it the next day, and the next day, and the next day. When things go wrong, that's the chance that we have to really, really learn. What about professional challenges? The biggest challenge that we have in palliative care comes from other doctors not being really aware what palliative care is. If they only knew what it was, didn't regard it as one of these myths, it would make a huge difference. I've heard people regard palliative care as giving up. I've heard people regard palliative care as all just about holding hands. I've heard people regarding palliative care as being unscientific. And then I've met many doctors who aren't clear when palliative care should begin. There's these difficult transitions. When the treatment goals change from curative to palliative, when death becomes inevitable, in the last days, in the last hours, from the point of diagnosis. there's so much uncertainty among our medical colleagues. And if there's uncertainty among our medical colleagues, how can our patients make sense of what palliative care is and what it has to offer? If we don't look for palliative care, we will just not see it.
This is an awareness test. How many passes does the team in white make? The answer is 13. But did you see the moonwalking bear?
Did you see the bear? And it's just the same with palliative care. If you're not looking for it, you won't miss it if it's not there. If you've got eyes to see it, you will see the need for palliative care everywhere. Okay. What does palliative care offer? Good symptom control. Yeah. Good communication. Really important. The biggest cause of complaints in the UK, maybe in Uruguay as well, is in doctors and nurses' communication. Disease management, correcting the correctable. We have an evidence base in palliative care, really important evidence base, trying to manage multiple morbidities. And then end-of-life care and bereavement. That's what we do. So to define especially palliative medicine, any illness, any age, any location. That's what we do. Any illness. These are patterns of the last year of life with function and time. Function and time. The cancer trajectory over time. At the start of the year, doing pretty well, proceed forward with time, and then slowly deteriorate. Usually in cancer, a reasonably guessable period. The dementia, frailty trajectory, the start of the year already functions quite low. And you see low level function, low level function. Palliative care has a lot to offer on this journey. But palliative care has also quite a lot to offer on this journey as well. In conversation with the family, in controlling difficult symptoms, in preparing families. But this is maybe the most difficult of all the patterns. You can see at the start of the year, function is already quite low. This is a patient with heart failure or respiratory failure, cardiac problems. And this patient is doing fine and then gets a chest infection, is rushed to the accident emergency department here. Fantastic job, the doctor, a brilliant job. Patient deteriorates, but the antibiotics kick in, the patient revives, goes back home. Fantastic hospital, the British hospital. It saved another patient. And a few weeks later, the same thing happens again. A few weeks later, the same thing happens again. A few weeks later, the same thing happens. The patient doesn't revive. Those people at the British hospital must have made a mistake. They cured Daddy every time before, now they've failed. This patient and this patient, their prognosis at the start of the year was the same. But nobody spoke to the family at this time to say that actually we need to plan for the worst and hope for the best. There's the lack of preparation, which then leads to all the bereavement problems and the aggression at that point. Does that make sense? Any location, in rural area, in the ICU, they both need the impact of a palliative care approach. Communication, crucial. It's what makes a doctor a good doctor. I've worked in places where there are doctors who have limited scientific knowledge, but who are fantastic communicators, and the patients love them. That ability to communicate, we are so much of what we do as doctors is work as placebos. When our communication is good, we are a much more powerful communicator. I've watched Dr. Cohen kiss so many people today. He is a fantastic placebo. Well, sorry. But that communication, it makes people feel good. Communication is really central. But how do you communicate in our world now, our Google generation, who will be checking everything you say online? That's tough. How do you say "I don't know" to the Google generation who demand answers? And so often in these areas we're dealing with uncertainty. And the doctor will say that if I refer to palliative care, they will know that the end is near. And sometimes, again, it's easier to say, "I'll see you in 6 months' time," than it is to admit that this is the last time we're ever going to see each other on this earth. What about the organizational changes for our admin people here in this fantastic hospital? And the problem in the West is that, by and large, our medical models have been changed dramatically. It used to be that we had an acute care model. You broke your leg, you went to hospital, the hospital fixed your leg. You got an infection, you got antibiotics, you were fixed. We had a fix-it model. But now in the UK, and I suspect in Uruguay, 85% of needs relate to chronic illness. And cancer has now become a chronic illness, a long-term illness. And so our models are set up for quick fixes, but the diseases that we're managing, like palliative care, are long-term conditions. How do we reflect the challenge to prevent, to detect, to educate, to help people to live with their long-term condition, their palliative condition? If we don't strengthen such services, the number of complaints and public dissatisfaction will continue to rise. We have never been able to do more as doctors. We've never had more bits of kit which allow us to do fantastic things. And yet we've never had more dissatisfaction in the UK, at least with our services. So, what have others done? They've created a specialist palliative medicine department. Some have done that, and they thought that was really important. And I think it's really important to have someone spearhead the department. They provided generous training in palliative care for all. It's one of the things we've really focused on in Northern Ireland, is providing generous training for all specialties, so that it's not left to Dr. Pires or to other palliative care people to look after those with heart failure at the end of life, or with respiratory failure at the end of life. That the specialties can do that well themselves. Others have seen it as really important to improve links with the local community, because that's where the majority of people want to be in the last weeks and months of life, so that we can transfer from our hospital to that setting as safely as possible. And creating connections and improving communication using electronic care records, and that has really made a difference. So that's what others have done. What about the ways forward? The WHO suggests that in order to improve palliative care services on a national level, there are 4 things which need to be done. And I think those 4 things are the same for a hospital as well. The first thing, if you really want to improve palliative care in your hospital, in your country, is what has already happened in Uruguay. You need a policy and a strategy, a signing up. You cannot just leave it to isolated individuals. There needs to be a strategy relating to the specifics, that we are going to be a hospital which takes palliative care seriously. And the 3 aspects of that are identifying patients who need palliative care, the right patients, assessing those patients and their specific needs, and lastly, planning with them the way forward which is suitable for them. And that may differ from patient to patient according to their specific needs. Okay. Educate, policy. We've got to have a strategy and a policy. The next big one, education. Education. I've worked in India recently. We've been developing palliative medicine. It's been recognized as a specialty. And we have 360 medical schools across India which now have to be taught how to teach palliative care. It's much easier in Uruguay. I think you have one major university and then a much smaller one. So that's 2 as opposed to 360. We need some place on undergraduate curriculum for doctors who, as soon as they come out, they are going to be looking after patients at the end of life. They need some skills, some understanding to be able to do that responsibly. Then we need training programs for generalists, those who are already involved in their own specialty, be it cardiology or gastroenterology or whatever, so that they can develop their palliative skills, maybe a diploma, maybe a certificate, something that can be recognized that this is a doctor who has those additional useful skills. Then lastly, there's this need for us to have a few real champions, real specialists, people like Dr. Pires, who can take that lead forward and be the champion to encourage the training, encourage the development across the unit. And lastly, it's really important for a hospital not to do palliative care, I think, in isolation. And that's the joy of ECHO, which could allow a unit like the British Hospital to connect with other units across the country who are facing the similar sorts of struggle. We have used ECHO in Northern Ireland for the last 6 months. We used it with our community rural teams. And one of their big complaints was isolation, that they felt that they were on their own. As you develop, you will also often feel a little bit isolated. But being with others who share that similar journey can be a big help. And also, by working together, you have a much stronger voice when it comes to speaking it to the health minister to have the services fully recognised. The third big link is medicine availability, making sure that good, appropriate analgesics, antiemetics, anxiolytics are all available, and that they're available within the hospital, and that staff know how to use them in a safe and an appropriate manner. And you need to audit that to make sure that that is happening, to make sure that your palliative care delivery is improving. Drugs as a model gives you that an example as a way of assessing that development. And lastly, implementation. And often the hardest bit, but you need to set yourselves a date to work with collaboratively with existing experts within the country, have clear goals, and implement in line with national and international standards. The standards are out there very clearly, how we can manage, how we can develop services. Having that as a guideline gives us a backbone for the quality of service that a quality institution like this could deliver. So I've overspent my time, but what I've tried to share is why I think this is so important. I've tried to go through some of the personal challenges, why it is so difficult, some of the professional challenges which we face in trying to develop palliative care services, the organizational challenges, the communication challenges, and some of the ways forward. But I want to finish with one more little video. There is a temptation whenever there's a new clinic or a new service to be thought about that we will think in terms of high-tech solutions. High tech can help us in many, many ways, but not all solutions necessarily are high tech ones.
Emma! Emma! Emma!
Thank you very much.
Muchísimas gracias, profesor Watson, por esta maravillosa conferencia. Mientras se ponen los auriculares y van preparando ustedes algunas preguntas, les quiero decir que seguramente todos se habrán quedado con la misma sensación que yo, de ganas de escucharlo más, y por suerte vamos a poder sacarnos las ganas. Están todos invitados el jueves a las 19 horas en el auditorio de Antel, donde va a haber otra charla diferente a esta, pero complementaria. Así que trae libre y estamos deseosos de que todos vengan. También el viernes a las 12 va a haber una conferencia en NH Columbia en el marco del curso de la Academia Nacional de Medicina, pero hemos decidido que dada la importancia del tema y sobre todo el conferencista, vamos a permitir la entrada a todos aquellos que quieran acompañarnos. Así que ahora estaríamos contentos, Jorge, nosotros el locatario, si tú querés dirigir las preguntas, y le agradezco mucho toda tu participación.
Como ustedes, quisiera preguntarle algo, que tenga alguna pregunta especial. Yo le haría una pregunta. ¿Es posible que una persona que puede estar en cuidados paliativos salga de ellos?
Absolutely. We have had patients who have been referred to us, who have responded really well to good quality palliative care, and we've been able to discharge them from our services. It's not about dying, it's about living and making living as good as possible for as long as possible.
Una pregunta. Es bastante habitual que un familiar nos llame antes de la consulta y nos diga, a mi papá no le diga el diagnóstico. ¿Qué opina usted que éticamente debemos hacer?
I think it is a very difficult situation, and it's one which requires you to use all your communication skills and all your knowledge and all the trust which the patient has in you. In that circumstance, I think it's important to spend some time with the relative who is concerned. Ideally to sit down, not to have that conversation in the corridor. To ask them why they think the way that they do. What are their concerns? Are they worried that their mother will give up if she knows she has cancer? I would try to convey to her that I realize that I may be the palliative care doctor, but that she is the specialist with her mother. She knows her mother really well. I would then try to let her know that I do not force information to her mother if her mother wasn't asking for that information. But if her mother asks an open and direct question, then I cannot lie to her, because my priority is to look after her mother. I can point out the difficulties that may arise if we start to lie, because if we lie at this stage, then down the line, your mother, and I would use this phrase of, your mother is not stupid. She knows she's seeing a palliative care doctor. she can put two and two together. If she thinks that we are all lying to her, she may lose trust just at the time when she needs us most together. So what am I saying to you? I'm saying I try to avoid this being a black and white issue. This is the right thing to do, this is the wrong thing to do. I try to explore it, and I try to give the relative the confidence to know that I'm not going to be imposing information which is not asked for. That's yeah.
My question is not a really medical one because I have medical experience, but how do you balance the resources you need as a medical care doctor? Because to my mind, potentially you need to spend more time rather than perhaps less time with the patient. And I guess that impacts on budgets and administration. And if that's whether it's separate for the palliative care doctor or whether it's in planning being part of your specialty, how do you balance that?
It's a really good question. Our surgery, our chemotherapy, our expensive bits of medical kit, our time. It's by using time, by having good conversations and by using time well, that we deliver our service. We don't question the oncologists when they are using drugs which cost $100,000 a year. I don't cost that much to have a conversation with a patient. But also, as we are trained and as we become skilled, often the length of time that we actually spend with patients may reduce. It's not about the length of time with patients, it's about the quality of time. That patient feels that for those 10 minutes, that time that we have, that I'm really there for them. So the side effects of expensive chemotherapy can be quite expensive. The side effects, maybe from spending that money on a palliative care doctor, talking to patients, I guess they can have some side effects, but maybe less potential. But very clearly, time, medical time, it's a significant resource, but it's a comparable resource to what other specialties are spending to deliver their service with patients. Yeah.
Una pregunta más.
¿Qué proporción de pacientes no oncológicos y oncológicos que existen en su hospital y qué criterios o cómo recomiendan promover los cuidados paliativos no oncológicos?
Thank you very much. Again, a really important question. We do not conduct what we would call diagnostic apartheid for patients to come into our service. It's about their need. It's about the patient need, whether that need is physical symptoms or emotional symptoms or psychological symptoms. So we currently, about 85% of our patients are cancer patients, but 15% are non-cancer patients. Our aspiration is that we will increase that amount to 50-50. But what we find is it's not us which are keeping those patients out, it's patients themselves. They don't want to come to palliative care services, they don't want to come to hospices. We're not dying, we're not like those cancer patients. And so if we really want to impact in improving the quality of life at the end of life of people, say, with heart failure, then we have to be very subtle, and we have to encourage our cardiology colleagues to do our work for us. Because the patients have a long-term relationship with their cardiologists, with their family doctors, they are the best people to deliver that care because they've got the long-term relationship. How do we develop that? We develop that by demonstrating improved care management by the use of ECHO. Our nurses across Northern Ireland are dealing with more and more patients with non-malignant diagnoses. And they're used to looking after patients with cancer, but not with patients with non-cancer. So supporting them is really important. But what we find is that the vast majority of the symptoms, be they cancer symptoms or non-cancer symptoms, are very similar. And the issues are very similar. So we're working closely with our cardiology colleagues and with our dementia colleagues. And we're finding that by joint training, that we're learning from them and they're learning from us. And our hope is that most generalist palliative care can be provided without access to a specialist service. But that whenever they reach that point where they need a specialist, they will know what to do. So that's our kind of our plan. Palliative care will never be able to look after everybody who dies in Uruguay. That's not the goal. The goal is to help other people to do that job as well as possible. You're very easy to talk to. I think you're very passionate about palliative care.
Yo quería hacerle una pregunta. ¿En qué medida los pacientes, porque dado el contenido de la conferencia del profesor Watson, quienes en gran medida han conducido, han hecho esto, al comienzo han sido médicos, pero sin embargo la realidad es que los pacientes están muchas veces más cerca del personal de enfermería, de asistentes sociales, de psicólogos, de sus cuidadores, y desde un poco su currículum que vimos que usted también tiene información desde el punto de vista teológico. Estos valores pueden tener que ver con cosas que de repente hemos pensado con más que ver. ¿En qué medida estas personas que en realidad terminan siendo los que están más cerca del paciente dependen de una figura médica que esté presente de alguna forma? Es decir, que el paciente no se sienta como que sí, que sí. En realidad el paciente necesita que haya una figura como todo el médico continuo o supervisando.
I think there's a way of looking at palliative care very similarly to obstetrics. When I worked in Nepal, I loved obstetrics. And palliative care and obstetrics are very similar. They're about getting a good delivery. And sometimes that baby will not come. And sometimes the patient will not go. And we just have to wait about a normal human experience. What the studies have shown is that people approaching the end of life, they invest great importance in the care that the main caregiver. Usually that is often a doctor, but it may be a nurse, it may be a relative, it may be a psychologist. But it's somebody who the patient identifies as being, if you like, their midwife. The person with the skill, the person who I'm going to trust to help me cross this journey. And providing the opportunity for that relationship to happen is a nightmare for administrators, because how do we make sure that the right person is there at the right time? And so that's where we think our role is supporting families to take on a large part of that job, because ultimately they are going to be the people who are there at the time, and helping them to be calm, helping them to anticipate what's going to happen, and to see that the end of life is a really important part of life. So you can regard the palliative care person as the midwife, or you can regard them as the orchestra leader, making beautiful end-of-life music, coordinating the different members of the family to make. But dying is not a medical event. Dying is a life event. And we are all in awe of something that we don't fully understand. And so I think we need humility, whatever our degree or lack of one is.
I realize that your talk has been mainly focused towards hospital and palliative care. I would like to know your opinion about what the palliative care mean within residences for the elderly, because they are, even if they're not sick, at the end of their lives. And then you have different places and different, within a community, or the people who live in the residence, and different, how many of they are to the end of their life. How would that work? What's your opinion about that?
It used to be in our country that when you visited a place like you're describing, you would see the cars of the residents outside. Now those days are long, long gone. And the average life expectancy when somebody moves into a care establishment in the UK is less than 18 months. So from the point of entry, it's palliative care. So I think the essence is all about developing relationships with the individual and allowing the individual to make choices. We would do, as part of the entry procedure into an establishment, we would do an advanced care plan. Not on the first day they arrive, but after a week, have a little bit of a chat, and have a bit more of a chat next week, and a bit more of a chat, to understand what the person actually wants and doesn't want as life draws to it. What's important to them? What are they prepared to put up with? And what are they not prepared to and that will differ from person to person. Some people will be happy provided National are they're able to watch National on football on television. They can cope with anything else. You understand? And it's finding out what is important for that individual and trying then to ensure that the care delivers that as well as possible. And so we've been involved in training all the care homes across Northern Ireland in basic palliative care, and in trying to ensure that good documentation is in place to prevent patients from leaving their home, because their home, your home becomes their home. And the risk is that patients get chest pain or run into a problem, and maybe they want to go into hospital, maybe they don't. But in the acute situation, they can be scooped up and taken into an unpleasant environment where they feel lonely and isolated, when it would be much more appropriate for them to be looked after by the people who know them best and have got the skills for doing so. But it's really important to give your nursing staff the confidence to say that to the ambulance men. And to have the documentation and to be able to be clear about what they want and what they don't want.
Si no hay más preguntas, damos las gracias al profesor Watson. Sí, y pues esperamos con Luis afuera para poder reunirnos entre nosotros, conocernos mejor, que no nos disfrutar de la